Welcome, everyone. Today, we're going to be doing a comprehensive tutoring session focused on CNS radiation oncology. We're diving into a really important topic, one that's very common, but also pretty complex when you get down to it. Meningiomas. We'll be working through some extensive clinical material, really aiming to build a solid foundation, especially helpful if you're a resident looking to get a strong handle on this.
Exactly. The goal today is really to equip you with a solid, evidence-based way to think about managing these tumors. We'll touch on the latest molecular stuff, differentiate the WHO grades, talk about the Simpson surgical grades for recurrence, detail the workup, and then really get into managing those WHO grade 1 tumors based on the evidence. You should come away with a much clearer picture of this key area in CNS radon.
Okay, great. Let's anchor this whole discussion with a typical clinical scenario. Picture this. A 58-year-old woman comes in. She's had headaches for months, persistent ones, and then, a new focal seizure.
Right, that combination definitely sets off alarm bells.
Exactly. So she gets a brain MRI. It shows a 3-centimeter mass, lights up brightly with contrast avidly enhancing, and it's dural-based. Left parasagittal region. And there's quite a bit of swelling, edema around it.
Okay, classic picture so far.
She goes for surgery. The neurosurgeon feels pretty good about it, thinks they got it all out. They even coagulated the dural attachment where it was growing from. We're going to keep this patient in mind as we go. Her case will kind of guide us through the key decisions we need to make.
That's a perfect case to start with. It really hits on several of the complexities right away. So to really understand her situation in, all similar cases, we need to zoom out a bit first. Let's talk about the broader picture, the epidemiology and the risk factors involved. The first thing that jumps out is just how common they are. Meningiomas. They are the most common primary intracranial tumor in adults, period.
Wow, most common. By how much?
They account for over 40% of all primary brain tumors in the U.S. So, yeah, a huge chunk. And what's interesting is the incidence seems to be going up.
Really? Why is that?
Well, a couple reasons. One is probably our aging population. People are living longer. But also, frankly, we're just better at finding them. Increased access to MRI, more scans being done for various reasons. We pick up more incidental ones.
Makes sense. And are there specific groups more likely to get them?
Definitely. There's a very clear female predominance. For the non-malignant types, it's about 2.3 women for every man. And the peak incidence for women is often cited as being between ages 35 and 44.
2.3 to 1, that's significant. Does that suggest hormones play a role?
That's the big question, and it's still debated. The link to hormone replacement therapy, for example, is controversial. Some studies suggest a link, others don't. No firm consensus yet. But the gender difference is definitely real and consistent.
Okay, so prevalence is high, incidence is increasing, strong female skew. What about established risk factors? What really stands out?
The number one most well-validated risk factor, the one you absolutely need to ask about, is prior exposure to ionizing radiation.
Radiation. How strong is that link?
It's quite strong. There's a clear linear dose-response relationship. More radiation dose, higher risk. And it's particularly pronounced if that radiation exposure happened when someone was young, say, less than 10 years old.
Like for treating childhood cancers or other conditions back in the day?
Exactly. Think about historical treatments, like radiation for tinea capitis decades ago, or maybe treatment for a prior brain tumor. The latency period can be really long, often decades later, so you need a good history. The radiation causes DNA damage, leads to instability over time.
Okay, radiation is key. What else?
Well, other factors consistently linked include elevated body mass index, or BMI. The exact reason why isn't perfectly clear, but the association is there. Also, certain inherited genetic variations, these germline polymorphisms, suggest some people might just be more predisposed. And then there are the specific familial syndromes.
Right, you mentioned those earlier. Which ones should we know?
The big one is neurofibromatosis type 2, NF2, also called MISME syndrome, multiple inherited schwannomas, meningioma, ependymoma. In NF2, there's a problem with the Merlin tumor suppressor protein leading to multiple tumors, including meningiomas. Another one, less common, is multiple endocrine neoplasia type 1, MEN1.
Got it. NF2 is definitely the main one to remember there. So, okay, we suspect a meningioma based on symptoms or maybe an incidental finding. How do we actually see it? What are those classic imaging signs?
Imaging is absolutely crucial. It's usually where the suspicion starts, and it guides everything else.
Right. And they often have a very characteristic look on MRI, don't they?
They do.
Yeah.
Typically, you're looking for a well-circumscribed mass, nice, distinct borders. It enhances homogeneously, meaning it lights up pretty evenly after you give contrast. And critically, it's dural-based. It arises from the dura, that tough outer layer covering the brain.
And what about that dural tail sign everyone talks about?
Ah, yes, the dural tail. You see that in maybe 60 to 70% of cases. It's this linear enhancement of the dura extending away from the main tumor mass. It usually represents reactive thickening, but sometimes it can actually be microscopic tumors spread along the dura.
Okay. And they push on the brain rather than growing into it, right?
Generally, yes. That's the extrinsic nature. A classic sign supporting that is the CSF cleft. You can sometimes see a little sliver of cerebrospinal fluid trapped between the tumor and the brain surface. And then there's the edema, the swelling in the brain around the tumor. That can be surprisingly significant, sometimes more than you'd expect for the tumor size.
There's so much edema sometimes.
It can be due to a few things: leaky blood vessels in the tumor, inflammation, maybe venous outflow obstruction. Certain subtypes, like secretory meningiomas, are particularly known for causing a lot of edema. And that edema itself can be a major source of the patient's symptoms. So those are the classic features on standard MRI. But we're getting better tools now too, right? More advanced imaging.
Absolutely. This is where things get really interesting. Octreotide PET, specifically using gallium-68 DOTA-tate, is becoming a really valuable tool.
Okay, DOTA-tate PET. Why is that so helpful for meningiomas?
It comes down to biology. Meningiomas tend to have a very high density of somatostatin receptors on their cell surfaces, particularly type 2. Gallium-68 DOTA-tate binds really strongly to these receptors, so the PE scan lights up wherever there's meningioma tissue.
Ah, so it's leveraging a specific biological feature of the tumor.
Precisely. And this makes it incredibly useful for several things. It can help delineate the true extent of the tumor, especially in tricky locations like the skull base. It's great for sorting out confusing postoperative scans. Is that enhancement scar tissue, or is it residual tumor? DOTA-tate PE can often tell the difference. It might even pick up other small spots of disease elsewhere that weren't obvious on MRI.
So it's really about getting a more accurate map of the tumor.
Exactly. It helps define the target volume much more precisely, which is critical for radiation planning. It can really refine our GTV. So here's a key takeaway, maybe a board pearl. Gallium-68 DOTA-tate PET is useful for imaging meningiomas because they express lots of somatostatin receptor 2.
Got it. That's a high yield point. Okay, so let's quickly summarize the essential radiographic workup. What are the must-haves?
All right, radiographic pearls for workup. Gold standard is definitely the MRI of the brain, both with and without contrast. That gives you the best soft tissue detail. And remember that specific sequence, T1 pre-contrast. Absolutely crucial for spotting bone invasion. The tumor looks dark, replacing the bright fatty marrow in the bone.
Right, T1 pre-contrast for bone, don't forget that.
Yep. CT scan is still very useful, especially for looking at the bony anatomy itself, any hyperostosis or bone thickening or calcifications within the tumor. Angiography, either CTA or MRA, is often needed if you're worried about vascular involvement, like encasement of arteries or invasion of venous sinuses. Important for surgical planning. And as we just discussed, that gallium-68 DOTA-tate PET-CT can be a powerful adjunct, especially for defining those tricky target volumes for radiation.
Okay, that covers the imaging comprehensively. So once we've seen the tumor, the next big step is understanding its biology and how much was removed. This brings us to the pathology and surgical classifications.
Right. These two things, the WHO grade from the pathologist and the Simpson grade from the surgeon, are really the cornerstones for deciding on management and predicting outcome.
Let's start with the pathology. The WHO classification, updated in 2021, is arguably the single most important prognostic factor. It tells us about the tumor's inherent aggressiveness.
Okay, walk us through the WHO grades. What defines each one?
So, grade 1, or benign. This is the most common type, making up about 90% of all meningiomas. Basically, they're defined by not having any high-grade features. Low mitotic rate, no necrosis, no brain invasion, generally well-behaved.
Okay, 90% are grade 1. What about grade 2?
Grade 2, or atypical, this is a really important category, but 7% of cases. And there are a few ways a tumor gets classified as grade 2. First is the mitotic count. If you see between 4 and 19 mitoses per 10 high-power fields under the microscope, that pushes it into grade 2. It signals increased proliferation.
4 to 19 mitosis. Got it. What else?
The second way, and this is a huge clinical pearl, is brain invasion. If the pathologist sees unequivocal invasion of the tumor cells into the adjacent brain tissue, it is automatically grade 2.
Wow, automatically, even if the mitotic count is low.
Yes. Brain invasion is like a trump card for grade 2. It doesn't matter what the other features look like. If it's invading brain, it's grade 2, because that signifies a much more aggressive biological behavior and a higher risk of coming back.
That's critical to remember. Brain invasion equals grade 2. Okay, any other ways to be grade 2?
Yes. A tumor can also be called grade 2 based on histology alone, if it has at least 3 out of 5 specific atypical features. These are things like sheeting architecture, where the cells grow in sheets, prominent nucleoli within the cells, hypercellularity, just more packed cells, small cells with a high nucleus to cytoplasm ratio, and spots of spontaneous necrosis, meaning cell death not caused by treatment. If you have 3 or more of those 5, even without brain invasion or high mitosis, it's grade 2.
Okay, sheeting, prominent nucleoli, hypercellularity, small cells, spontaneous necrosis. That's a lot to track. Is there an easy way to remember those 5 criteria?
There is. A good mnemonic helps here.
How about HASN? Stands for hypercellularity, architecture, sheeting, small cells, high NC ratio, spontaneous necrosis, and nucleoli prominent. HASSN for the 5 minor criteria for grade 2.
Perfect. HASSN. That's a great one. And one last point for grade 2. Certain specific histologic subtypes are automatically designated grade 2 just based on their appearance, like chordoid and clear cell meningiomas. They just behave more aggressively.
Okay, HASSN. Got it. Now, what about the highest grade, grade 3?
A WHO grade 3. These are anaplastic or malignant meningiomas. Thankfully rare, only 2 to 3%. But they have a much worse prognosis. Diagnosis here requires a mitotic count of 20 or more mitoses per 10 high-power fields. Very high proliferation. Or, and this is a key update in the 2021 classification, certain molecular features automatically make it grade 3.
Ah, molecular markers again. Which ones?
Presence of a TERT promoter mutation or homozygous deletion of the CDKN2A and B genes. If either of those is found, it's grade 3, regardless of the mitotic count or histology. These molecular changes are known drivers of very aggressive behavior and even metastatic potential.
So TERT promoter or CDKN2AB deletion equals grade 3. That's another crucial takeaway. Any histologic subtypes automatically grade 3.
Yes, papillary and rhabdoid subtypes are automatically considered WHO grade 3 due to their historically poor outcomes.
Okay, that covers the WHO grades, which tell us about the tumor's biology. Now, what about the surgery itself? You mentioned the Simpson scale. How does that fit in? It's pretty old, right?
It is old, developed by Dr. Simpson back in 1957. But it's still remarkably relevant, especially for grade 1 tumors. It grades the extent of surgical resection, how completely the surgeon thinks that they removed the tumor and its dural attachment. And it directly correlates with the risk of local recurrence after surgery alone for those benign grade 1 tumors. It captures that idea that leaving even microscopic bits behind increases risk.
Okay, let's break down the grades. What defines a Simpson grade 1?
Simpson grade 1 is the best case scenario surgically. It means complete macroscopic tumor removal, plus resection of the involved dura where the tumor originated, and resection of any involved underlying bone, aiming for total removal.
Grade 2.
Grade 2 is also complete macroscopic tumor removal, but instead of cutting out the dural attachment, the surgeon coagulates it. They burn or cauterize the dural base. Our initial patient case had a grade 2 resection, remember?
Right, coagulation of the dura. Okay, grade 3.
Grade 3 is still complete macroscopic tumor removal, but this time the dural attachment is neither resected nor coagulated. It's basically left alone, maybe because it's in a dangerous spot, like over a major sinus.
Got it. So grades 1, 2, and 3 are all considered complete removal, macroscopically, just different in how the dura is handled. What about grade 4?
Grade 4 is a subtotal resection. This means the surgeon knowingly or unknowingly left macroscopic visible tumor behind. Maybe it was stuck to vital structures or just too extensive.
And grade 5?
Grade 5 is just a decompression or biopsy. The bulk of the tumor is left. Surgery was just to relieve pressure or get a diagnosis.
Okay. And you said this correlates with a recurrence. How strong?
Very strongly, especially for grade 1s. Here's a great clinical pearl, sort of a rule of thumb. For a WHO grade 1 tumor, the 10-year recurrence risk is roughly 10 times the Simpson grade number.
Wow, really? So like grade 1 resection, about 10% risk at 10 years.
Around that, maybe closer to 9% in the original data. But yeah, roughly 10%. A grade 2 might be closer to 20%, grade 3 maybe 30%, but a grade 4, the subtotal resection, the risk jumps way up, over 40% recurrence at 10 years.
That's a huge difference. Really highlights the importance of achieving a complete resection if possible.
Absolutely. In modern terms, we often group Simpson grades 1 to 3 together as achieving a gross total resection, or GTR, versus grade 4, which is a subtotal resection, or STR. That GTR versus STR distinction is key for deciding on further treatment.
Makes sense. So we have the WHO grade and the Simpson grade. Before jumping into treatment, let's quickly summarize the comprehensive workup needed.
Right, putting it all together, what do you absolutely need? First, always a good history and physical. Ask about headaches, seizures, vision changes, smell changes, any focal deficits. That guides urgency. Imaging. MRI brain with and without contrast is the cornerstone. Remember T1, pre-contrast for bone invasion, CT for bony details, angiography, see TAMARA, if vascular involvement is suspected, and consider gallium-68 dotatate PET-CT for complex cases or target delineation, biopsy. Usually not needed beforehand if the imaging is classic, but you need tissue from surgery for definitive diagnosis and grading, and molecular testing. Increasingly important, especially if the grade is borderline, like between 1 and 2, or if you see brain invasion in an otherwise benign-looking tumor. It helps refine prognosis and might guide future therapies. Look for NF2, CHAIT, CDKN2AB, etc.
Okay, comprehensive workup done. Now, the big question, how do we treat WHO grade 1 meningiomas? What's the algorithm?
All right, let's talk strategy for grade 1s. The initial approach really depends on the patient's situation. If you have a patient who is completely asymptomatic, the tumor is found incidentally, and there's no significant mass effect.
Like a small one found on a scan for headaches that turned out to be unrelated?
Exactly. In that case, the standard initial approach is active surveillance. Just watch it with serial MRIs. Typically, you might scan again at 3 months, then 6 months to see if it's growing. If it's stable, you can often stretch that out to annual scans.
So I just watch.
Because many of these small asymptomatic grade 1s never grow or cause problems, so you avoid the risks of surgery or radiation if you don't need to intervene. Of course, if you see clear radiographic progression on those follow-up scans, or if the patient develops symptoms, then you pivot to treatment.
Okay, surveillance for the small, quiet ones. What if they are symptomatic? Or the tumor is causing mass effect? Or the patient just really wants it treated?
Then you move to therapeutic intervention. And for grade 1 meningiomas, surgical resection is the mainstay treatment. The goal is always to achieve the most complete resection safely possible, aiming for that Simpson grade 1, 2, or 3.
Right. So let's say the surgeon achieves that gross total resection, Simpson 1 to 3, for a WHO grade 1 tumor. What's next? Do they need radiation afterwards?
This is a really important point, backed by good evidence. For a WHO grade 1 tumor with a gross total resection, Simpson 1 to 3, the standard is observation. No adjuvant radiation therapy.
No radiation, even though you mentioned recurrence can still happen long-term.
Correct. The evidence comes largely from RTOG 0539, group 1. They took patients exactly like this new grade 1 GTR and just observed them. The 5-year progression-free survival was excellent, 86%. That's strong level 2 evidence supporting observation. The thinking is the risk of recurrence is relatively low in the short to medium term, and you want to avoid the potential side effects of brain radiation if you can, especially for a benign tumor.
But you did mention that long-term, like at 25 years, maybe almost half can recur, even if you're GTR.
That's the nuance, yes.
Yeah.
Long-term follow-up is still crucial. Complete resection significantly lowers the risk, but doesn't eliminate it entirely over decades. But initially, after GTR for grade 1, observation is standard.
Okay. Now, what about the other scenario? WHO grade 1, but the surgeon could only get a subtotal resection, Simpson grade 4, or maybe even 5.
Now the conversation changes quite a bit. This is a higher risk situation. With a subtotal resection of a grade 1, you have known residual tumor left behind. Here, the options are generally observation versus adjuvant radiation therapy.
What's the risk if you just observe after a subtotal resection?
It's pretty high. Local progression rates at 5 years are often quoted in the range of 40 to 60%. By 10 years, it can be 50 to even 100%. That residual tumor is very likely to grow.
Wow, that's almost guaranteed to progress eventually. So radiation seems like a good idea then.
It often is. Adjuvant radiation therapy, typically delivering 50 to 54 grays in standard fractions, can significantly improve local control in this situation. It helps sterilize that known residual tumor. The decision between observation and adjuvant RT depends on factors like the size and location of the residual, the patient's age, health, and preferences. But RT is very frequently recommended after STR of a grade 1.
Okay, so RT is key after subtotal resection. What about using radiation as the primary treatment? Like if a tumor is unresectable or the patient isn't a surgical candidate?
Yes, definitive radiation therapy is an excellent option in those cases. We have different ways to deliver it, depending mostly on the tumor size and location.
Let's talk about stereotactic radiosurgery, SRS. That's the single high-dose shot, right?
Exactly. Single fraction SRS is great for smaller, well-defined grade 1 meningiomas, usually less than 3 centimeters or so, and not right up against critical structures like the optic nerves. Typical doses are around 12.5 to 16 gray, prescribed usually to the 50% isodose line. And the results are very good. 5-year local control rates are often over 90%. Plus, it's convenient, just one treatment session.
Over 90% control, that's impressive. What if the tumor is a bit bigger or too close to something sensitive for that single high dose?
Then we often turn to hypofractionated SRS, or sometimes just called fractionated stereotactic radiotherapy, SRT. Instead of one big dose, we break it up into a few smaller doses, typically over a week. A very common regimen is 25 gray in 5 fractions. This is often used for tumors maybe 3 to 5 centimeters, or those hugging the optic chiasm or brainstem. It gives normal tissues some time to repair between fractions, potentially reducing toxicity while maintaining high control rates.
Is there good data for that 25 and 5 regimen?
Yes, there was a prospective trial looking specifically at this for larger or critically located meningiomas. It showed really high 5-year local control, around 97%, with pretty low rates of significant side effects, about 12.7%. So it's a very effective and safe option for those intermediate cases.
And for the really big or complex ones?
For very large tumors, or maybe those with very irregular shapes where SRS or SRT is difficult, we use standard conventionally fractionated radiation therapy. This involves delivering smaller daily doses over several weeks, typically to a total dose of 50.4 to 54 gray over about 5.5 to 6 weeks. This maximizes normal tissue sparing for extensive disease.
Multiple excellent radiation options depending on the specifics. Now, what if a grade 1 tumor comes back? It recurs after initial surgery, maybe years later. How do we approach that?
Recurrent WHO grade 1 meningioma is definitely considered a high-risk situation. The fact that it came back tells you something about its biology, even if it was initially called benign. If it recurs after prior surgery alone, then adjuvant radiation therapy is strongly recommended. We typically treat to 54 gray in 30 fractions. This aligns with the intermediate risk group, group 2, in the RTOG 0539 trial. You treat that recurrence more aggressively because it has proven its potential to grow back.
Okay, recurrence bumps up the risk significantly. Let's dive into the practical side of planning this radiation. Precision is obviously critical in the brain. How do we actually set this up?
You're absolutely right. Precision is everything. The setup starts with simulation. The patient lies supine, usually immobilized with a custom thermoplastic mask to keep their head perfectly still. We get a planning CT scan, typically with contrast. And then the crucial step is fusing that CT scan with the diagnostic MRI scans both the pre-op and the post-op MRI if they had surgery.
Why both pre-op and post-op MRIs?
The pre-op shows the original tumor size and location. The post-op shows the surgical cavity and any residual enhancing bits. Fusing all three gives you the most complete picture, accounting for any shifts in anatomy after surgery. And again, on that MRI fusion, you're paying close attention to that T1 pre-contrast sequence to look for any subtle bone involvement.
Got it. Fusion is key. Now, defining the targets, what exactly goes into the gross tumor volume, the GTV?
The GTV includes the visible tumor. If it's post-op, that means the surgical bed or cavity, plus any definite nodular residual enhancement you see on the post-op MRI. Here's what's important not to include routinely. Don't just contour all the surrounding edema, that's just swollen brain, not tumor, and don't routinely include the entire smooth, diffuse dural tail.
Why not the dural tail? Isn't that associated with the tumor?
It is. But most of the time, a smooth, thin dural tail is just reactive thickening, not packed with tumor cells. Including, it unnecessarily expands your radiation field into normal tissue. Now, if that tail looks clearly nodular or bulky and enhances brightly, okay, then you might include that specific part, but not the whole diffuse tail as a rule.
Okay, GTV is the definite tumor bed plus nodular enhancement. What about the clinical target volume, the CTV, which accounts for microscopic spread?
Yeah.
How big is that margin for grade 1?
This might surprise you. For a WHO grade 1 tumor that had a gross total resection, the standard CTV margin is actually 0 millimeters. CTV equals GTV.
Zero margin, really.
Yes. The rationale is that for a truly benign grade 1 tumor that's been completely removed, the risk of microscopic cells extending beyond the visible edge is considered very low. However, if it's a recurrent tumor, or if it was a subtotal resection, then we do add a margin, typically 0.5 centimeters, so 5 millimeters, around the GTV to create the CTV. That accounts for the higher risk of microscopic spread in those situations.
Okay, 0 millimeter CTV for GTR grade 1, 5 millimeter for STR or recurrent, and then the PTV.
The PTV, planning target volume, adds a margin to the CTV to account for daily setup variations and potential small movements. A typical PTV margin is 3 millimeters. And to make sure that margin is adequate, we use daily image guidance, usually with onboard KV X-rays, KV guidance, to precisely align the patient before every single treatment fraction.
So GTV, then CTV, or 5 millimeter, then PTV 3 millimeter with daily IGRT, and the dose again for conventional treatment.
For external beam, typically 54 gray in 30 fractions. Or if doing SRS, that 12.5 to 16 gray single shot.
You know, planning this radiation sounds incredibly meticulous. I like to think of it like being an expert dart player. You're not just vaguely aiming at the board.
That's a great analogy.
You're not just aiming for the bullseye, the GTV. You're mapping out the entire dartboard, identifying exactly where the optic nerves are, the brainstem, the cochlea, the hippocampus, all those critical organs at risk. And then you use sophisticated techniques like IMRT or VMAT, maybe even protons, to shape the radiation dose, ensuring your darts hit the tumor precisely while meticulously avoiding those vital structures. It's all about maximizing tumor kill while minimizing collateral damage.
Absolutely. That's the core principle of modern radiation oncology, especially in the brain. Minimizing dose to normal tissues is paramount for preserving quality of life and neurological function long term. We have to be constantly aware of potential side effects, both acute like fatigue and late like neurocognitive effects or even rare secondary cancers, and plan meticulously to reduce those risks.
Okay, fantastic. We've covered a huge amount of ground. Let's try to synthesize this with some key clinical pearls, the absolute must-know takeaways.
Sounds good. Let's recap. First, epidemiology. Remember, meningiomas are the most common primary intracranial tumor. Big female predominance over 2 to 1. And the big risk factor to remember is ionizing radiation, especially at a young age.
Right, and WHO grading. Grade 2 is key, 4 to 19 mitosis, or that trump card, brain invasion, or 3 of 5 atypical features, HASSN mnemonic. Grade 3, 20 or more mitosis, or molecular markers like TERT promoter mutation or CKN2AB deletion.
And the Simpson grade for surgery correlates with recurrence. That rule of thumb is helpful. For grade 1, 10-year recurrence risk is roughly 10 times the Simpson grade number. GTR 1 to 3 versus STR 4 is the key distinction now.
Treatment evidence. RTOG 0539 Group 1. For newly diagnosed grade 1 after GTR, observation is standard, 86% 5-year PFS, level 2 evidence.
Definitive RT for unresectable grade 1. SRS 12.5 sexatine GI or hypofractionated SRT like 25 GN5 gives excellent local control over 90%. Standard fractionation 50.454 poor G for larger ones.
And a crucial point, recurrent grade 1 tumor. Treat this as high risk. Adjuvant RT to 54 gray in 30 fractions per RTOG 0539 Group 2. Intermediate risk.
And finally, 2 radiographic pearls. Remember T1 pre-contrast MRI for bone invasion, dark tumor replacing bright marrow, and gallium-68 DOTA tape PEE is useful because of high somatostatin receptor 2 expression, helps define targets.
Excellent summary. Those are definitely the high yield points. Ready for a quick board blitz? Test how well these concepts stick.
Let's do it. Always good practice.
Okay, question 1. A meningioma is resected. Pathology notes 12 mitosis per 10 high-power fields, but no brain invasion. What's the WHO grade? A grade 1, B grade 2, C grade 3, or D? Cannot be determined without Simpson grade.
Okay, 12 mitosis falls right into the 4 to 19 range for grade 2. No brain invasion mentioned, but the mitotic count alone is sufficient. Simpson grade affects prognosis, not WHO grade. So the answer is B, grade 2.
It's exactly. Rationale, spot on. Question 2. A 50-year-old has a Simpson grade 4 resection of a WHO grade 1 meningioma. What's the approximate 10-year recurrence risk with surgery alone? A, less than 10%, B, 10-20%, C, 20-30%, or D, greater than 40%.
Simpson grade 4 means subtotal resection. We use the rule of thumb. Risk is roughly 10x Simpson grade, so 10 by 4 equals 40. The risk is high, definitely greater than 40%. So the answer is D. And this patient would be a candidate for observation versus adjuvant RT per RTOG 0539.
Perfect logic. Final question number 3. A 60-year-old patient, asymptomatic, newly diagnosed 2.5 centimeter WHO. Grade 1 meningioma. What's the most appropriate initial management? A, definitive SRS to 16J. B, surgical resection. C, observation with serial MRIs. Or D, fractionated RT to 54GA.
Okay, key factors. Asymptomatic small, 2.5 centimeters is less than 3 centimeters, and grade 1. In this scenario, the standard initial approach is observation with serial MRIs. Many of these won't grow. RTOG 0539 Group 1 supports this for low-risk cases. So the answer is C.
Fantastic. You nailed all three. That really shows a good grasp of integrating the pathology, surgery, and evidence. Now, let's bring it back to our initial patient case. The 58-year-old woman. Remember, she had a Simpson grade 2 resection GTR. But her pathology wasn't grade 1. It came back WHO grade 2, atypical, based on a mitotic index of 8 per 10 high-power fields, no brain invasion.
So she fits perfectly into the next level of complexity. She has a grade 2 tumor, even with a gross total resection. That situation is going to be the focus for our next session, right?
Exactly. Her case becomes the bridge. Managing WHO grade 2 and 3 meningiomas is where things get even more nuanced. We'll need to talk about the role of adjuvant radiation even after GTR for grade 2, how we handle grade 3 tumors, strategies for re-irradiation if these higher grade tumors recur, and touch on the emerging landscape of systemic therapies. There's always more to learn.
Absolutely. It's a constantly evolving field. Understanding the foundations of grade 1 management, which we covered today, is essential before tackling those higher grades.
Well, that brings us to the end of this deep dive into the foundations of meningioma management. We've covered the epidemiology, the crucial WHO and Simpson grading, imaging essentials, and the evidence behind treating WHO grade 1 tumors. Hopefully, you now have a really solid framework for these cases.
Yes. The goal was to provide those building blocks. Remember, understanding the why behind the guidelines is just as important as knowing the guidelines themselves. Hopefully this analysis helps with that complex decision-making you face. Keep questioning, keep exploring.
And if you want to reinforce this material, do some practice oral boards, or explore further, you can find more resources over at radonsmartlearn.com. That's radonkSmartlearn.com. Definitely join us next time as we continue exploring CNS radiation oncology, tackling those grade 2 and 3 meningiomas. Thanks so much for tuning in.